My Vancouver Bone Squad lecture in 2025 was the most watched Vancouver Bone Squad lecture in that year, ending Dr. Resnick's reign after 2 years, so I'm quite proud of that. So they were inviting me again to talk about something this year. And in this video, I will show you my Vancouver Bone Squad lecture about the topic transient osteoporosis of the hip or the death of thereafter. So when you are a doctor or a radiologist and you come across the term transient osteoporosis of the hip, definitely this video is for you. So let's dive right in. And after the lecture, I will show you another research paper that I was not talking about during the presentation, but one of the viewers then reached out to me after the lecture and sent me this link to this research paper, which I think underpinning the message that I do during this talk. So definitely watch until the end so that you can also see the result of that particular research paper that I missed in my initial preparation. So watch the video now and then I'll see you at the end again.
Okay, hello everybody. My name is Chris and I'm gonna talk about hip MRI in today's lecture. I'd like to thank Vancouver Bone Squad again for inviting me this year after last year's lecture, and I'm looking forward to talk to you about bone marrow edema in the femoral head and the death of transient osteoporosis in the next 40-45 minutes. So let's make this full screen and we can dive right in. Just as a little disclaimer, I've got a MSK MRI focused YouTube channel where you'll find a lot of also hip related stuff, also last year's lecture about labral tears, and you can find this all here. Just search for my name on Google and I'm sure you will find it. Okay, so why did I choose this topic? Now, very frequently in my virtual MSK fellowship, I have fellows who present cases like this. Ritish posted this case, transient osteoporosis of the hip versus stress fracture. And this was a fellow doctor, the patient, who played table tennis 15 days ago and then started to complaining of gradually increasing hip pain. And the confusion that Ritish had was, is it transient osteoporosis or is it the stress fracture or insufficiency fracture? Now in a younger guy, he was considering stress fracture. So let's dive into this case here. And this is the very typical presentation, 35-year-old male patient. And we see the bone marrow edema here in the femoral head. And we will come back to this case later. But this is the confusion, right? So people see bone marrow edema and then the two differentials they try to solve is transient osteoporosis of the hip versus a subchondral insufficiency fracture or stress fracture. And that's what we try to answer in today's lecture. So the learning objectives are to understand the history and the nomenclature of transient osteoporosis and transient bone marrow edema syndrome in the hip, and learn about the differential diagnosis of bone marrow edema in the femoral head. And ultimately, I want to show you a simplified approach to this finding. Now, ultimately, you can think of bone marrow edema as like the shade of a creature. And if you think, what is this? What's the animal behind this shade? Then that's what we try to resolve today. The terms we're going to focus on are transient osteoporosis, transient bone marrow edema syndrome, subchondral insufficiency fracture, and this is kind of like the three different animals that we can expect from the same finding on MRI or similar finding, and ultimately AVN. But AVN is kind of like a little bit an outlier, as we will see later in this presentation. Okay, so let's go back in time a little bit because we need to understand how everything came together and why we have this confusion today. In 1959, there was the first mentioning of this transitory demineralization of the hip in pregnancy in 3 cases by Curtis. And a few years later, 9 years later, that was when the first time transient osteoporosis of the hip was used as a term in the literature. Now, this is way before any MRI were available. Now, in 1988, that's when Wilson reported the first time transient marrow edema syndrome in a patient with, or in patients with self-limiting joint pain in 1998. And then subchondral insufficiency fractures in the femoral head on MRI were first described in 1996. And this follows the technological progress that we observed at the time. Now, when you plot this on a timeline, like I tried to do here, sorry for the messy board, the kids were putting stickers on and I was not able to get it off. But anyways, so in 59, transient osteoporosis of the hip. Avascular necrosis has been there like forever. This was well known before that already. It was a separate entity. there. And then with the advances of MRI, we started to see this transient bone marrow edema syndrome. And initially, they said, okay, we see this edema, but we don't see it on radiograph. So, it was kind of like a separate thing. And only with time, then people started to think, okay, maybe this is a precursor of this, and the two merged somewhat together. And then people were starting to think, oh, wait a minute, potentially these transient bone marrow edema syndrome or these things could potentially progress to AVN, or maybe it's even a early AVN situation. And even that came close together here. And then at the, close to the 2000s, the subchondral insufficiency fractures were put into the mix. Now, if you've been trained in this period or were practicing in that period, you probably have experienced these terms, and you might have one opinion and maybe you don't believe in the other opinion or whatever. But I think I've seen people being more confused if they had some form of training in the 2000s, especially also with early AVN and bone marrow edema syndrome as potentially a precursor. So let's have a look into this. This is an example from the literature from 1993, where they show the demineralization of the femoral head as an example for transient osteoporosis of the hip. Now, for some reason, the acetabulum is also participating, which I don't quite understand. So there might be an additional technical issue here. But that's basically what you see, the mineralization of the femoral head in transient osteoporosis of the hip. And if you think about this, it makes sense. You see demineralization, so you can call it like osteoporosis, and it's transient because if patients then come back after, let's say, 6 months or whatever, this goes back to the same density as before. But the problem goes beyond that. Like even in more recent review articles, people are referencing the older articles and the nomenclature is not quite straightforward. So look at this article from 2021, where they show different types of fractures on MRI. Now, this one here was supposedly a patient with known bilateral femoral head osteonecrosis, or AVN, with now a fracture line, as they describe it, with perifocal edema and some flattening and collapse. Now, that's fine. But this one is the confusing bit. So they describe this very nicely here as a, this line here with the yellow small arrow, a insufficiency low signal intensity linear fracture. So it's a very complicated name to call it a subchondral fracture, is shown there. And then we've got the bone marrow edema and the sparing sign here, which we will see later. And ultimately, the final diagnosis was transient osteoporosis. So they use transient osteoporosis, but describe it as a subchondral insufficiency fracture. And I think that's part of the confusion, and also in the literature that we will see later. Now, this one here was a completely separate setup with a stress fracture or fatigue fracture. So I think it's confusing. The terms are overlapping, and then some people think it's not overlapping and might be precursors, but then others say it's not. So I think I want to give a little bit of a clarity in this regard. And I think one thing we should not forget, and this is mainly true if people start citing in review articles of the past, is the evolution of MRI image quality. We see here in 1993, that's how MRI looked like at the time. So I wasn't practicing then, so I took this from the literature. But you can see everything is just bright. You can see the cortex. You don't really see anything else. Like, it's very difficult. You can't separate really the labrum, cartilage. Like, it's difficult, right? Even in 2012, you see bone marrow edema. Resolution is somewhat better, but still, like, if you have to decide, is there a subchondral insufficiency fracture, it might be quite tricky. There's some pixels here which are a bit darker. Maybe there's a little bit here, but at least we see now the labrum. We have somewhat of understanding of where the cartilage is. But in, excuse me, in 2026, the resolution has become far superior than it was in the past, of course. We see everything. We see much more nowadays. And you can see a subchondral insufficiency fracture right here. We see a lot of edema. And something like this would easily be missed in the past, even 10 years ago. So we have much better image quality. And I think this is something we need to keep in the back of our minds moving forward in this lecture. So as of now, in 2026, there is inconsistent terminology that changed over time. We have these terms: transient osteoporosis of the hip, transient bone marrow edema syndrome, subchondral insufficiency fracture of the femoral head, early AVN, transient migratory osteoporosis, and transient migratory bone marrow edema syndrome. There might be others, but this is basically the main bunch of it. So we have inconsistent terminology, we have increasing image quality with better resolution, and we have outdated and partly confusing literature, which comes together by citing articles from the 90s and from the 2000s, when in fact we should probably do a new research study with really nice image quality rather than just relying on articles of the past when the tools we had were not optimal. So I want to give you now a simple framework and understanding of what I think is going on. So we have this mountain, we have these different terms, and we try to come up with a solution, and it's very confusing for many, many people. And I know this from all the coaching that I do. So people have these questions and it's not clear for most people what to do. And what I want to do by the end of this lecture, we want to have a clear path. Okay, so that's the goal. And this is the question that I want to ask you. What if transient osteoporosis of 1959 is actually just a subchondral insufficiency fracture that was not visible at the time, and today we can actually see it? Okay, that's the hypothesis that we want to try and look at now. In 59, the tools were limited. This was one of the early X-ray machines. And today we have powerful 3 Tesla or even 7 Tesla MRI scanners. And we have much better resolution and image quality. So there's no surprise we see more. We might see the underlying etiology of a descriptive term that was used before. Just to compare this again here, I showed you this image quality again. And I think if we would have better image resolution in this image from an article from 2020 or 12 or something, I would argue potentially there might have been a subchondral fracture, or even here. We don't know. The resolution doesn't really allow us. And also, as you can see, this is coronal, this is sagittal. Sometimes, these lines are more in the anterosuperior quadrants. So we would not even see this on a single image like this. I think the sagittal would be preferred. And often people scan in like a whole pelvis rather than a single joint. And then you don't have a proper sagittal view where you not even would find these anterosuperior subchondral fractures at all. Now, I know some of you already thought about this. This is the main argument I hear when I come up with this hypothesis, that people say, okay, wait, Chris, the problem with your idea is that the prevalence or the distribution between men and women is completely different from what you would expect from subchondral insufficiency fractures. And it's true, the article that people mean, or where this statistics is coming from, is this one here. I think it's from 2012 or something, by Dr. Klontas and Karantanas, so from Greece, where they looked, I think, the largest series, 155 hip joints on MRI, and they found the transient osteoporosis of the hip prevalence in men or male was 76% and only like 24% in women. And this is counterintuitive if we say this is subchondral insufficiency fracture. Okay, but if you actually go into the article, that's what I did, and you read their material and method, you see that they had exclusion criteria for how they excluded people that are not part of these 155 cases. And one of the exclusion criteria was in fact insufficiency fractures confirmed by MR imaging. So when they saw a insufficiency fracture on the MRI, they excluded the patient from this study. Okay, so they didn't really give much more detail, like what is an insufficiency fracture, to exclude a patient. So I went on LinkedIn, I wrote Dr. Klontat's email or like a message, and I asked him, okay, in your research study from 2015, what did you actually exclude? Like, what was the criteria for exclusion? Because ultimately in their results, they found fractures still. So he answered that, thanks for the message. In the exclusion criteria, we are talking about the typical insufficiency fracture seen in elderly patients, which is strictly immediately subchondral. I think that's probably the image that I showed you. In close proximity to the cortex, that do not traverse deeply into the marrow of the head. The fractures we have identified in the study are lines that go from the cortex deep to the femoral head bone marrow. And in addition, the typical population is the classic transient osteoporosis middle-aged patient and not the elderly population where subchondral fractures traditionally described. But age was not an exclusion criteria, only the presentation of the fracture, okay? And even gender was not exclusion criteria. They primarily looked at, is the fracture pretty much straight below the cortex, or does it go deeper? And then let's have a look at the images that they show from this research study. And I think that's what he meant. Like, you've got a fracture that goes deep or deeper into the marrow, and you have some marrow sparing, or like there's a distance between the fracture line and the subcortical layer here, or the cortex itself. Now here even is more subtle, but this was also marked as a fracture, and there's a little bit of maybe sparing, but this is not really like, you know, the typical subchondral fracture, like with this thickening only of these cortex layers. Same here, okay, and then here. So these are the typical fractures that they've seen. Then this is another case from the same article where they now use the term regional migratory osteoporosis syndrome, because the patient also developed something in the hip, in the knee, and we know now that these things in the knee are really just subchondral insufficiency fractures, and it's not like, you know, transient or SONC or osteonecrosis or transient osteoporosis of the knee or whatever, or transient marrow edema syndrome of the knee. I think this has been established in the literature by now that it's subchondral insufficiency fractures of the knee. But patients also had the same thing in the hip, so that's why they came up with this. And we don't really see a fracture on this single image here. I think that's why this was not excluded. But again, they don't show any sagittal images, so I'm not sure if we actually would have picked it all up. And with higher image quality today, we could argue maybe potentially something like this, or maybe there's some thickening here. There could be somewhere a subchondral insufficiency fracture. So this 76% versus 24% difference towards male, in my opinion, is probably a little bit, or could be, I don't have to prove, but could be that it's because women have generally weaker bone in that age group, and they might show these very subtle subchondral insufficiency fractures a little bit more prominent than, like, for example, men, and therefore they might have excluded a unproportional high amount of women because these fractures were better visible in female patients on these old images, and therefore they were excluded, and we have therefore a male predominance, potentially. There's, you know, I can't really prove this. I asked Dr. Klontas a follow-up question, but I haven't received an answer to this theory yet. But this is a fracture they probably would have excluded, because on older scanners, I don't think we would have seen this little bit of edema between the fracture line and the subcortical or subchondral line here, okay? So this is something to keep in mind, that there might be a bias in this article because they were excluding subchondral insufficiency fracture by design. And then if you go into the, you know, the general radiology literature like Radiopedia, they say transient osteoporosis of the hip and subchondral fracture lines can be found in almost half of the cases, but they don't really describe this like Dr. Klontas did in his answer, where it needs to go deep into the bone. So these are just subchondral fractures as such, right? And the fact that subchondral insufficiency fractures were actually excluded, it doesn't really sit well with me in a description like this. And this statistics actually comes exactly from this mentioned study. Subchondral fractures were present in around 50% of the hips. So they excluded all the insufficiency fractures, and still 50% of cases had a subchondral fracture that was just a bit more deeper, and the other ones didn't have any. And whatever was in between was excluded, and I think that's where the female gap comes into place. Okay, so yeah, we saw this already. This is the confusing time period where subchondral insufficiency fracture was put into the mix, and we will now try to go further. Okay, so this is something that has been described as a feature of transient osteoporosis of the hip. That's why I want to bring it up here before we go into the next topic. It's called the medial bone marrow edema sparing sign, and this is something that has been described as a typical finding for transient osteoporosis of the hip. And you see this here. You have this bone marrow edema, and the medial or the infromedial part of the femoral head is spared. Often you don't see edema in exactly this location, and it has been described as a typical finding here. And the reason for this is most likely the composition or the orientation of the trabecular structures. As you can see here, we have this area where there is a bit of a change in the orientation of these trabecula. And the fact that we have these different groups, like the tensile group, the compressive forces, or tensile or compressive force group, they cross here, and the edema, if we have an insult or like a fracture up here, the edema and the hemorrhage starts to come up in here, and I think it's just diverting along these lines more down, whereas this one here is not really a lot of compression anyways, and therefore maybe there is sparing in this particular area. Now, just one thing to say here, this sign here, it has been shown, is only typically present early on. Once you go further in time for transient osteoporosis or subchondral insufficiency fracture, this is going to vanish. So even if you don't have it, it's not going to really help us in separating these two, potentially different entities. Okay, so this is some interesting, I think, side note here, where there might be some sparing. I think it's just the orientation of the trabecular structure where there is a little bit of less compression forces, so this is not so much affected, and only later on, when there is enough time passed or the trabecular stress increases, it might affect these inframedial parts of the femoral head as well. So, and this is now the most important question. We have this, these different terms. Maybe it's the same thing, maybe it's not. But does it even matter? I think that's the main question that we have to look at now. So let's have a look at the clinical side of things. Now, so far we've only been describing the radiology part, and here we can look at symptoms and the therapy that the clinician will do. Let's start with subchondral insufficiency fractures of the femoral head. It's typically characterized by an acute onset of hip pain, no dedicated trauma or no super trauma present, and it progressively worsens over time. So it starts quite suddenly and then it gets bad or worse over time. Then the treatment is protected weight bearing for up to 8 weeks. Okay, so this is basically acute hip pain, and weight bearing is the therapy of a fracture, which of course makes sense. Okay, so let's have a look at the same thing for transient osteoporosis of the hip or transient bone marrow edema syndrome. It starts with sudden pain and then it gets worse over time. There has been asymptomatic cases, but basically it's the same thing as for subchondral insufficiency fractures, and the treatment is limited weight bearing. So to summarize, basically both entities have the same symptoms, sudden pain or acute onset of hip pain, and the treatment is the same with limited weight bearing or protected weight bearing, which is essentially don't stand on a limb that has a fracture somewhere. Okay. Now, let's have a look at the histopathology. The histological specimen, I'm just reading this now. The histological specimens reveal a focal region of altered bone trabecular architecture covered by osteate seams and active osteoblasts associated by formation of callus. Nearby tissues are characterized by the presence of edema, fibrosis, hemorrhage, and vascular congestion without findings compatible to AVN. And this is now for you to answer in the chat. Do you think this is for a transient osteoporosis of the hip, or is it for a subchondral insufficiency fracture, this result of a biopsy that has been done in a case? So I give you a few seconds. You can type in chat here in the Zoom link whether you think it's TOH or SIF. So I'll just give you a few seconds and then we'll see what you come up with. So I didn't want to give you the answer before reading this. Now, if you read this, altered bone, trabecular architecture, formation of callus, edema, fibrosis, hemorrhage, and vascular congestion. Okay, I can't see the live results, but I hope to see some of you answering in chat. Anyways, let's continue. This is the question, is it TOH or SIF? And it's actually from transient osteoporosis of the hip. So this is the histopathology of a transient osteoporosis of the hip. And I think that's why some people think that vascular congestion might be a cause for this transient osteoporosis, and it's something that men then maybe have for whatever reason more likely because it's more prevalent in men, and it's actually not a fracture. But if you read these things, the callus, altered trabecular architecture, to me this is pretty much a description of a fracture where you also expect edema, fibrosis, hemorrhage, and with the insult there will also be some vascular congestion and pressure from the hemorrhage, etc. So that's totally understandable for me. So let's recap. We have the same clinical presentation for both entities, we have the same treatment, and we have the same histopathology. So the conclusion can only really be it's the same thing. And transient osteoporosis of the hip is maybe like a mythical creature from the past, and it's that now. Like, I think it's a misnomer, and we should just go on, and that's what I at least do, call it a subchondral insufficiency fracture of the femoral head. And maybe this year, or maybe it takes a couple of more years, we will come to this conclusion or consensus on a more general basis, similar like we think today that SONC is SIF, maybe transient osteoporosis will be called subchondral insufficiency fracture of the femoral head, especially should there be like more research coming out that ignores the past and just basically tries to repeat the same research studies with better image quality, something that people don't do, because then where is the novelty? It's not very, people are not incentivized to repeat studies of the past. Okay, so the diagnosis or the challenge is not really, is it transient osteoporosis of the hip or subchondral insufficiency fracture? Because in my opinion, it's the same thing. Now, even if you want to have a strong opinion that these is separate things, treatment is not going to change and the symptoms are not going to change. Okay, this is up to you. But the challenge that we have now is the separation of subchondral insufficiency fractures from early AVN. Not the typical AVN that we know all, like with this rim and everything, but the early on, because some people think that bone marrow edema can divert into a AVN, and bone marrow edema or transient osteoporosis of the hip could be a potential, or one of the differential could be early AVN. So we have two questions to look at next. First question, is bone marrow edema without a fracture a potentially early AVN? And can subchondral insufficiency fractures progress into AVN? So let's have a look at this article that tries to answer exactly this question. And they asked, is bone marrow edema syndrome a precursor of hip osteonecrosis, 50 patients? And their conclusion is that the subchondral lines and spots found in patients with bone marrow edema syndrome do not develop into AVN. So they all, in this series, they were not developing any of them into AVN. And you've probably seen this in the knee, where you have the subchondral insufficiency fractures in the subacute or chronic stage. Sometimes we see T1 hypointense areas directly where we had this initial fracture, but they do not represent AVN. It's most likely some reparative processes in the subchondral bone, etc., that kind of like creates a little bit of different signal that can be mistaken for like maybe secondary AVN, as some people try to call it. But ultimately, I think the etiology is different, and there is no evidence that this is developing, that bone marrow edema syndrome or subchondral insufficiency fracture develop into this. So the other question is then, is transient osteoporosis of the hip, like the bone marrow edema, can this then merge or progress into a necrotic thing? And in this article, Karantanas, and they described already in 2011 that it's widely accepted that bone marrow edema indicates, in patients with AVN, an advanced stage of AVN. So the bone marrow edema we see in AVN, if you see it, it's a poor prognostic sign and typically comes from a secondary collapse of the necrotic bone. And it cannot be found before the appearance of the band-like sign. So these bands, this is the typical hallmark of avascular necrosis of the femoral head. This comes first. We don't have the situation where we see a large bone marrow edema that then develops these lines as a demarcation. That's apparently, according to the literature, not the case. And I think it's confusing because in the olden days, we had these articles like this where they say biopsy-proven early stage AVN, where they had an MRI with very, very bad image quality. They show a most likely fracture line, and it's not quite clear, because if you read the caption, this wasn't biopsy proven early stage AVN. Okay, so what was it actually? The radiograph was normal, the patient was asymptomatic, and this finding has been incidentally seen while imaging for a transplanted kidney. For some reason, somebody had the idea that this is a good idea to actually do a biopsy here, and then they found something and called it, this is early AVN. And I think there is a problem here, because when you have a lot of these edema and subchondral insufficiency fractures, the bone marrow, as I've shown you also before, undergoes these changes. Like it has to heal the trabecula, we have callus formation, we have granulation tissue, etc. and even vascular congestion, like what we've seen before. And there's also fat necrosis as part of it. And I think that's probably where some of the early biopsy results came to the conclusion that we are looking at a AVN when they did a biopsy of some of these cases. But they were actually, concluding this, but they were not really looking at the actual cell death of the bone itself. It's what's concluded or deducted from this finding. And because the way they do these biopsies also, if you have a subchondral insufficiency fracture or transient osteoporosis where it's very, very subchondral, they will not biopsy the actual location of the fracture. Therefore, they will not necessarily see the proper fracture. And it's kind of like, a misinterpretation of this thing where they incorrectly published that bone marrow edema as proven early AVN. And I think this is, again, it's a classic thing from the past, which is not really supported in today's literature. And I think the modern consensus now is and should be that early AVN does not show bone marrow edema. If you see bone marrow edema in the vascular necrosis, it's already in the later stages. We see the demarcation of the necrotic part, and the edema happens if this necrotic piece in the weight-bearing area starts to collapse. Flattening of the head, collapse of trabecular structure, and it's basically a secondary fracture of this necrotic piece of bone. And as such, it has a poor prognostic sign. So it's for later stages. It's not in early AVN, okay? Then the typical finding in subchondral insufficiency fractures is the edema is also massive. It always or nearly always reaches down into the femoral neck. And the fracture lines can be very, very subtle. And I've shown you these nice images, and we can go over a couple of cases here later. These lines sometimes are not really separated from the subchondral plate itself, but are just presenting as a thickening of it. And I'll show you this in some cases. And if you don't see a line, even on a good scanner, there's a potential to call it a subchondral stress reaction, but ultimately I think you just have to look again and find the area where there is some thickening, and you should have a unilateral field of view, and I'll go into this in a bit. So how to separate subchondral insufficiency fracture from AVN? I think this is fairly straightforward. I will not go into AVN for time reasons, but the fracture lines in subchondral insufficiency fracture of the hip are parallel to the cortex, very close to it. Sometimes they can go a little bit deeper, like we've seen in the 155 case study from 2015. Whereas AVN demarcation is like this, the line is like this, and the line is here like this. But here, if you see this edema, it's already a sign, it's collapsing. You see the femoral head is flattened. This is a round, nice head, whereas this one is flat. So there has been some collapse happening here, leading to flattening of the head. And this is more like an advanced case where we had necrosis and then secondary collapse. So I think this is easier to understand and separate like this. So my recommendation is, if you have a bone marrow edema in the femoral head and neck, use unilateral field of view. Just scan the one hip, or maybe you have one whole pelvis view, but then go to the hip in question, because otherwise you might not depict the actual fracture line. And I use subchondral insufficiency fractures. I haven't used transient osteoporosis of the hip in years. Even transient bone marrow edema syndrome I haven't used. And if you don't see a fracture, you just have to look again, and be very sensitive in finding it. And then I think it makes it easier for everybody to understand, okay, we're looking at a subchondral insufficiency fractures. Maybe they need to check the bone quality, history. Maybe they need vitamin D supplementation, check for osteoporosis or whatever. Or patient, it's maybe also easier for a patient to understand why he should, do protective weight bearing as opposed to some transient bone marrow edema syndrome where people think maybe there is vascular congestion going on. Like, why should I not be able to walk? So I think it's just a better term. Okay. So I think it had its time, like this was the knowledge at the time. And now in 2024, 2025, 6, etc., I think these are the two main pathways that remain. And these other things, I think, are a relic of the past, like as in the dark ages of radiology. Okay. So let's go over some cases, and I'm going to try to open these here. Okay, so let's start with the first case here. So this patient had a car accident or like a pedestrian accident 10 weeks ago, and since 3 weeks, the pain has been increasing. And when we look at these images, we can start with the radiograph, and you see in comparison to this hip here, I'm not sure if you can see this on the stream, the cortical line is somewhat diminished, and we have a little bit of a increased lucency here in the femoral head. But nevertheless, it's not needed to go into more details here because we have an MRI. And you see there is a lot of edema. We've got the typical medial sparing here, and we have effusion, etc. So now the question is, okay, is this transient osteoporosis or is there a fracture somewhere? And we can now try to find the fracture because I told you, I believe these are all just fracture lines. And when we look carefully here on the sagittal, I think it's always one of the better sequences. It's very subtle, but you see some thickening or condensation here that are, I think, consistent with calling this a fracture. The T1 sometimes also is a bit better, and I think you can see and understand there is a little bit of a thickening of the area here that can potentially explain this as a fracture line. And I'm not sure this one is not helpful. Okay, so yeah, I think I'm very sensitive in these areas, and that's why in this case I would also call a subchondral insufficiency fracture. And even the history I think is fitting. So patient had a car accident, there was some injury happening, and the patient had pain, and then was maybe not walking a little bit, created a disuse osteopenia, and then maybe he was picking up activity again, and then sustained this subchondral insufficiency fracture. And that's it. So I think that's happened here in this case. So let's go to the next case here. So this is Ferdinand's case, and again, hip pain, 52-year-old female. And the question he had was also, is this transient osteoporosis of the right hip, or is there a anterior subchondral fracture? Exactly the same scenario. And I think this is really where people have a lot of concerns. And when you look at this, there's no radiograph available. You're looking at the MRI here and PD fat set on the coronal. We see there's some sparing on the medial side. Posterior aspect is not really involved, so we have mainly anterior superior edema here. And then let's go to the sagittal here to understand what's going on. And we can see here where we have the bone marrow edema. If we center this or try to demarcate it, we have this area here where there is some thickening and irregularity in this area. And even here you can kind of see there is a bit of a dent, or like a flattening, if you will, of the sphericity of the head here. And I think this is where there is a subchondral collapse. And if we go, there was no trauma, it's just basically a history of groin and hip pain here over time. And I think this is again where we have a trabecular injury here with a little bit of collapsing of the trabecular structure and creating this focal edema around it here with a little bit of effusion and synovitis. I don't think we can see, let's see if we have a T1. So let's have a look at the T1. But the T1, I think, also shows very irregular trabecular structure, but because it's coronal, we don't really understand what's going on here. And I think this is where the sagittal and the hip dedicated protocol actually helps you in identifying these anterosuperior issues. Because on the coronal, if you scan like this, you have no idea what's going on here, okay? So this is another case where I would just use a subchondral insufficiency fracture. And this is a female, 52 years old, which might have been excluded in the previously mentioned research paper, okay? So let's go to the next case. Okay, so in this case, Catherine has again a question, severe left hip pain, no relevant history, and whether to call it transient osteoporosis of the left hip because she is seeing a fracture. So let's go into the case, and we see immediately extensive bone marrow edema in the whole of the femoral head, maybe some subtle medial sparing, which has been described for transient osteoporosis, but typically edema reaches also into the femoral neck. We've got a little bit of an effusion. And so the question we have now, where is the fracture? That's the first thing that I would do. And if you scroll on a coronal again, I think we have some limited, with some limitations there. So I prefer a sagittal, which I think is just easier to see sometimes. And when we scroll through here, there are a couple of areas which for me stand out. I think here is a PD fat set. So we have some form of a line here in this area. So let's see if we can also see this on the coronal. And I think we see here this line here, which if the cortex is going over like this is in the subcortical region. And again, I would just call this a subchondral insufficiency fracture given the history of no trauma or no relevant history and severe left hip pain. And that's it. So I don't think I would use the term transient osteoporosis of the hip in this case. And, despite the medial sparing, whatever. If you have the insult here, the hemorrhage starts, it goes down like this, and then maybe it takes just a bit more time to reach all over to this area. There is even a second area where we can potentially argue there might be a subchondral insufficiency fracture in the more superior supramedial parts here. And I think this is where the resolution comes into place, right? So it's good image quality, but it could be a little bit better still. We might have a T1, but again, the T1 is only full pelvis. We don't have a unilateral T1 here, which makes it hard to see if there is any like trabecular collapse that we can convincingly call out here because of the limited resolution. Okay, so let's go to the next case. So this is Ritish's case that I showed you at the start of today's lecture. The fellow doctor who started playing table tennis and I think was only 35 years old. And the question, stress fracture versus transient osteoporosis of the hip. So let's go in. I showed you the images before. We see this edema. We see the typical medial sparing, and you can potentially call it, okay, transient osteoporosis of the hip. No. But let's try to find the fracture. And if we go, I would recommend again using some sagittal image, and then we go here, and you see there is a little bit of thickening in the subchondral area here, this one here, that is not just normal or like nothing. It's the same thing here. You see the sphericity of the head would normally go like this, but this looks like a horizontal line. And it's not just the resolution. I think it's just very, very subtle, but this would be the typical subchondral insufficiency fracture that we exactly use the same way to diagnose on the knee, which we now call SIF rather than SONC. It's the same thing for the femoral head. And these cases, from what I understood in these 155 case articles, that would be a case that they would maybe have excluded if somebody had the idea this could be a fracture. But I think they wouldn't say this is a fracture. They would say, okay, there is no fracture. We've got medial sparing, this bone edema, and this would be for them a typical case of transient osteoporosis of the hip. But as a young guy and he started playing tennis, 35 years old, he probably did an activity he wasn't used to. Maybe there was some underlying vitamin, we don't know, issue. It's just a overuse situation with a subchondral fracture. Whether to call it insufficiency or stress fracture, that's then a second discussion. But definitely this is not just, nothing. Like this is not the normal situation. You can also see on the other femoral head, the cortical line is very well round. There's no like this horizontal flattening. It's not happening. And I can try to show this on a sagittal, maybe even better between the two. So I need to desync. So let's go in here and let's go in here. So you see this area here. This is just not quite right and it's still synced for some reason. Okay. And then here, if you scroll through, the sphericity of the head is looking fairly smooth. Okay. And here on this one, we have these areas where it kind of like bumps in a little bit here. Okay, so let's go to the last case. Okay, so here we have pain in the left hip for 10 weeks, 51-year-old male patient. And the main finding again is bone marrow edema. It's a bit less intense than in the other cases, less effusion. We've got typical medial sparing, so people would think, okay, typical case, transient osteoporosis. But let's find the fracture. We can start on the T1. It's always a good way to start. And if you see the beautiful sphericity and the normal subchondral plate here, and you look here, you start to see there is a condensation of the trabecular architecture in this area here as a potential location for a subchondral fracture in this location. Okay, this is not normal. The trabecula are not going horizontal in the subchondral plate, like they go like this. We've seen the compression trabecula here, which you can come down further here. We've got the tensile ones, but there shouldn't be like any line that goes somewhere like this. Okay, and if we go to the image here, it's a bit less easy to see on there's a PDFAT set here. There's not necessarily a dedicated line that we can easily identify. So let's try the sagittal here, and even here we can appreciate this is probably the location where we seen this, or somewhere here. Again, resolution here is one of the limiting factors, but I think I've seen enough on the T1 to confidently call this a subchondral insufficiency fracture. The radiograph will not really show much, so there's no help there. Okay, So let's go back. So these were the cases here from my fellowship, and you see it's a frequent question where people have this exact doubt. These are the references. I know you can make a screenshot if you want to deep dive into the literature and the history. But I want to end with the take-home point here. Extensive bone marrow edema in the femoral head is very much likely a subchondral insufficiency fracture. Early AVN does not show bone marrow edema, okay? And the terms, or the term I use is subchondral insufficiency fracture of the femoral head. I'm not using transient osteoporosis of the hip. I'm not using transient bone marrow edema syndrome or transient migratory bone marrow edema syndrome at all. Now, whether you want to do this or not is up to you, but since it has the same symptoms, same treatment, it's not super important, but I think this is just technically the better term. And that's why I think it's time to put the transient osteoporosis of the hip on the side and just go with the subchondral insufficiency fracture. So that's it. Thank you very much for your attention. I hope this was helpful. If you have any comments or questions, you can send me an email, or you can scan this QR code and join the free MSK Radiology community on School, where we can discuss stuff like that. And yeah, thanks for the invite again to Vancouver Bone Squad, and thanks for watching. Okay, and welcome back. Now this is an important part here of this video, because after I was giving the presentation for Vancouver Bone Squad, Dr. Jeffrey Belair reached out to me here. You can see his email. He is an associate professor of radiology at Thomas Jefferson University. And he sent me this research paper that they did. And it was great because they were actually looking at retrospectively at cases that were diagnosed as transient osteoporosis of the hip, and they anonymously identified subchondral fractures in 88% of the cases on small field imaging. So let's have a look at this paper, which basically says all the cases that previously have been diagnosed with transient osteoporosis of the hip in that particular setup were having visible subchondral insufficiency fractures. So basically exactly what I was saying. So let's see what they come up here with. This was from 2024. So I don't know why I missed that, unfortunately. Okay, well, I didn't do a systematic review, but anyways, I should have found this, especially since it's from skeletal radiology. Okay, so transient osteoporosis of the hip is uncommon, typically self-limiting diagnosis, Labber. We hypothesize that represent an underlying subchondral fracture, and discrete fracture line can often be detected on high-resolution imaging. So this is basically the exact hypothesis that I was talking about in my presentation. So they looked at this, and they were then, we can go maybe straight to the results. So they had like 29 females. The others were probably male, and then mean age was on the higher end here, but large range in terms of age. Average duration of symptoms, again, a large range. Okay, subchondral fractures were identified in 44 out of 50 cases, so 88%. And good correlation, joint diffusion. Okay, so very nice. So discrete subchondral fractures were identified anonymously in all of those. So let's have a look if we can actually see the paper here, which we have to come back in a second. Give me 1 second. Okay, so it's unfortunately behind a paywall. I tried different things, didn't get free access, but I'll show you a trick. You can just go to images and you can see that Google actually can see behind the paywall. So you see these are the images from this article, and you can see they always show these very, very subtle fracture lines here that you can see here, here, here. And these were cases that they were referring to as transient osteoporosis of the hip initially. So very nice study here. So thank you very much, Jeffrey, for sending me this paper, or this link to this research paper here. And yeah, so basically this just, makes the point, right? So transient osteoporosis of the hip is just a misnomer. It's a relic from ancient days. And I think we don't have to wait until 2030 to just call them subchondral insufficiency fractures, and we can just forget this. Yeah, thanks for watching, and I'll see you hopefully next year with another Vancouver Bone Squad lecture. Bye-bye.